free to jump in. Feel free to jump in, interrupt me at any time. We have an hour, and this is only really a half an hour talk. So I'd like to have a conversation and hear about everyone's experience using the technology and what have been the barriers for you all, because that can help us. We can learn from that as well and understand better how to help you all through IVUmed if we can get back down and visit again soon.
Okay.
So this is a surgical management guidelines talk. It's primarily geared towards U.S. residents and understanding the American Urologic Association guidelines for the preoperative evaluation of stones, and then the guidelines related to stones in the ureter, stones in the kidney, and then some special cases. Again, this is just American guidelines, and so it doesn't, every place is a little bit different with what the practice is there and the culture. And I'd love to just hear about where there's mismatches, because I think that teaches us a lot. So feel free to jump in. For the purpose of this talk, I'll use the shorthand of URS, meaning ureteroscopy or retrograde intrarenal surgery, PCNL being percutaneous nephrolithotomy, and then as well SWL being shockwave lithotripsy. So the first kind of workup, if you saw this on a KUB or had an ultrasound, what are the first things you would order preoperatively? Our guidelines are fairly specific about this, that you would always want to get a urine analysis, and if concerned for infection, a urine culture. Practically, we get both of them at the same time and interpret that. We get a CBC if there's concern for blood loss, and certainly if any open stone surgery or percutaneous procedures, that would apply. Ureteroscopy or shockwave, I think that concern is less, and so we don't often necessitate that. But I do always want to make sure that our patients have a basic metabolic panel, or at the very least a creatinine, just to make sure that we're ruling out renal dysfunction, and so that we know if there's problems afterwards, kind of what our baseline is. Would also order a non-contrast CT scan in this case, because we had an X-ray of a clear staghorn stone. The ultrasound shows it, but we need to rule out other problems around the kidney, and that's why an X-ray and an ultrasound alone is insufficient. And so we see things like this. If you're planning a percutaneous approach, this is an axial scan CT with stone in the left kidney, and you can see here a pretty clear retrorenal colon. And for doing the percutaneous approach, that's going to be a serious issue. If we scroll down, you may see that there's a window where the colon does not exist, or is more medialized, but certainly you want to know this ahead of time before sticking needles into the kidney, especially if you're using fluoroscopy as your image guidance. Now, the advantages of using ultrasound, which I use primarily as the initial imaging study intraoperatively, is that you would see the colon if you learn to recognize it. And again, that's on my other talk. You can see the signs on ultrasound that show that the colon is between the surface, or where you're imaging, and where you're trying to get your percutaneous puncture. So that's something to watch out for. Spleen can also be in the way. On the right side, the liver, all those things you'll pick up on CT scan. I've even seen a large redundant splenic vein that was serpiginous throughout the retroperineum and could have potentially gotten in the way of a percutaneous procedure. So we always recommend a CT scan prior to a percutaneous procedure. If you suspect a non-functioning kidney with stone, again, looking at that CT scan, something like this, where a patient's had a long history of this stone, at least as far as we can tell, and you have a clearly atrophic right side of the kidney. Do you need to treat that stone? I think that's arguable if they're asymptomatic, but you want to confirm that truly is a non-functioning kidney, even if the kidney looks atrophic on CT scan, you can't always predict that. And so we often do DSMA or DTPA. MAG3 really is the standard that we have available to assess the function. Is that a study that's available where you're at all?
Negative. We don't have that.
Yeah. So when you're assessing kidneys, what do you look at to kind of determine?
Usually the first imaging exam that we ask for is ultrasound.
Mm-hmm.
And you have to understand that in Haiti, we have some financial limitations with most of our patients, right?
Absolutely.
We try not to ask for too many lab exams if we can do with what we can have. All right. So basically, we usually ask for an ultrasound. And depending on the dilation of the renal calyces, we can have a presumption of the function of the kidney or not. But if we have doubts, we do ask for a contrast CT scan or an IVP, right? But we don't have DTM and say this nuclear evaluation of the functioning of the have that. So it's IVP or contrast CT scan.
So when you get an IVP or contrast CT scan and you see delayed nephrogram or delayed drainage, but a patient has an obstructing stone, how do you interpret that?
Well, we try to have delay when we use IVP. We try to have delay until the 24th hour images film, I would say, and just to see. That's it. We cannot do differently.
So you get one right away at 15 minutes or so, and then you get another one at 24 hours to see if there's residual or retained contrast?
Exactly.
Interesting. Yeah, so in a case like this, for example, what would you, if the patient, say, is complaining of pain on that right side, and what would be your initial approach given that that kidney looks so atretic?
To tell you the truth, when I was watching this image, for me, this kidney might not be functioning.
Right. Totally agree.
There is not many chances. Even though it retains the smallest function that it can have, I'm sure that on the long term, this function will deteriorate. So this kidney might be a good candidate for removal.
Just go straight to nephrectomy.
Yeah. What do you think?
Yeah, I agree. Yeah.
What do you think about putting a double J stent in and watch like 2 or 3 weeks after to see how it goes?
The thing is, there seems not to be too many parenchyma. It's very thin, if not absent. That's the point. Yes, we can do that. Before envisioning the nephrectomy, put a double J stent and reevaluate after 1 to 3 months. Well, that could be done also. As you can see, he's a very conservative guy.
Yeah, that's the other thing I notice here is that, you know, despite this stone clearly being obstructing, this stone being atrophic, there's not very much hydronephrosis, which also makes me agree with Dr. Brutus that, you know, this is a suspect kidney for any function, and I think you could feel pretty confident about taking that out. You know, clearly you can see this lady's had an American diet for too long. What do you have access to laparoscopic approaches, or would this be an open nephrectomy?
No, we don't do laparoscopic yet.
Yeah.
Okay.
It's gonna be open surgery.
Open nephrectomy, yeah.
Yep.
All right. Well, thank you for that discussion. And then this was mostly for the residents. I'm sure everyone here knows this, but the MRI is not helpful in kidney stone disease. If you do happen to see one, the stone's gonna be dark on T2 weighted imaging. And you can see here the stone in the middle of the right pelvis, and then some calyceal partial staghorns, but it's not a good imaging test. So here's a video. It's just like a kind of fun imaging. Anybody feel like they have a confident diagnosis there looking at that?
This kidney, I would give it a chance.
Yeah, this lady is a young woman, 35 years old, just had a baby, and just had kind of chronic right-sided flank pain. Finally got a CT scan. Never had stones in her past. Really no UTIs of any concern. And she clearly has this sort of blown out kidney with dilated calyces and this central stone. And then if you look on the next, well, I have another video I can show you later. Basically, if you looked at the contrast phase, this bottom part of the kidney here and the kind of anterior portion of the kidney, I mean, it looked pretty good. And so again, I agree with Dr. Brutus. I wanted to give this kidney a chance. And so what I did was I perked into this space to try to clear her stone. And the kidney just looked awful. I mean, there was old debris. She wasn't actively infected, but there was a lot of old crud in there. I tried to clear out the stones, but it was very hard to see everything. I got, I think, 70% of it. There was one calyces that was still blocked. Despite doing the PCNL, I just couldn't reach it because it was so large and kind of redundant. I just couldn't see it. But I left her with a nephrostomy tube to try to drain the system and get it to cool off. And it just never got better. It stayed dilated. It stayed, you know, she had trouble with the nephrostomy tube. And eventually we had to just take out the kidney, which was kind of sad. But I think she already had the XGP kidney pathology happening within the parenchyma. So that's xanthoma granulopilonephritis, and it's where the foam macrophages actually start to replace the parenchyma of the normal kidney. And at that point, it's believed that the kidney is relatively unsalvageable because you're never going to clear that infection. So despite her clinically feeling well, I think that kidney was shot.
Yes. And indeed, on this film that we have here, you can see how thin the parenchyma is. So, well,
exactly. Yeah. Do you see pathology late in the game like this a lot in Haiti, where the kidney's kind of been blocked for a long time and people are late to present?
Absolutely, because usually our patients, they come to consultation very late, the disease, because when they have this renal colic, the first thing they think about is gas, you know. So all they try all kind of medication, empirical medication, you know.
Yeah.
And when they do finally come, usually we have a big grade 3 or 4 hydronephrosis, and sometimes so we had to take the kidney off. And when you tell them that the kidney is not viable, that you will have to take it off, they go away, and it takes them some time to come back.
Yeah.
And you know, at the time there is no chance at all.
Yeah.
So very familiar kind of cases. But we have to admit, you will help me with me maybe, we have to admit, since that we have this ESW machine and the laser, I have to admit that the patient are more aware. So we are starting to receive the patient earlier now. But
so word is getting out that you have some access to more minimally invasive treatments, and the kidney is maybe more salvageable, or?
No, we don't have many invasive approaches yet. We're talking about PCNL, right?
No, I mean shockwave and ureteroscopy. I think those are minimally invasive. Yeah.
Yes, we do have shockwave and the laser, but one of our biggest problem is that we have the rigid, the semi-rigid sorry, the semi-rigid ureteroscope. We don't have the, so sometimes it's more difficult to use it, in the kidneys than in the lumbar portion of the ureter. So we try to do with it, but sometimes it's very difficult.
Yeah, so for those proximal ureteral stones, do you end up using shockwave first, and then if the stones get obstructed, going in with the semi-rigid?
Yes, but we try to favor the DSWL first. If
Right.
the kidney is big, and sometimes, depending on the patient financial possibilities, sometimes we ask for the CT scan, the non-contrast CT scan, and calculate the Hounsfield unit to have an idea. So
Right.
it's not all. The thing is, the vast majority of our patients cannot afford the CT scan. So we have to evaluate we have our Hounsfield calculation in our eyes from what we see on the KUB.
Yeah. I bet it's not far off, honestly.
So
you
that's
see enough of them.
Particularity of our practice here in Haiti.
And how often are you able to put stents in?
Oh, Yuri, very often, right? Yuri.
Yes. Most of the time when we have stone bigger than 2 centimeters, and we think that we can have the Steinstrass thing, so we put the double J stent before doing it.
Before the shockwave?
Yes, and it's a small stone, or we think, according to what Dr. Brutus said, with our eyes, that it's not a hard stone. So sometimes we don't put the double J stent. But most of the time, when it's bigger than 2 centimeters, and we see that it's pretty dark in the KUB, so we put it in before the ESW procedure.
That's nice. I mean, that, if we often hear, we don't always put stents up ahead of time. Often we don't, because we're not treating the bigger stones that way. But occasionally we do for patients that have to have shockwave, for example, because they have a conduit and it's not so easy to access them, or in cases where they've had a prior stent that gets encrusted and we can't get the proximal curl to break up and pull out. We'll often use shockwave to break that the stone around the curl and the encrusted stent, and break it up with shockwave as we pull it out. Seems to work pretty well. What's your follow-up after you shock a big stone like that with the stent in? Do you do serial x-rays and then eventually take the stone out? Do you usually end up looking up with the semi-rigid to clear the distal ureter, or what's the usual outcome?
Our protocol is to have a KUB 1 month after the procedure. And if the patient is clear of stones, we pull out the double J stent. As you say, very, very rarely, we have to say it doesn't happen too frequently that we can have the Steinstrasse. So we do it by with the ureteroscopy, but it's very rare.
Yeah,
because
that's good.
We are very cautious on selecting the patient that would be eligible for ESWL.
That's great.
We're trying to be very selective.
What machine do you have?
We have a Dornier, but the first generation.
Delta 1.
Delta 1, nice.
Delta 1.
Yeah, I mean, they all work. So, I think that's a great strategy, and it sounds like it works for a lot of patients. You can get a lot done with that.
But our biggest issue is those staghorn calculus, or those that are bigger than 2.5 centimeter. Sometimes all the patients don't want to have the open procedure. So we are very, uncomfortable to let them go, because we know that during the ESWL for this patient, we might have a lot of complications. And as a matter of fact, I remember that I had at least one. He had a lot of complication because I let him know that it wasn't possible because his stone was too early. And he told me, he insisted, and he told me that he wanted to have the SWL, and as predicted, he has this spine stressor and all kind of complication until he lost the kidney.
Yeah, that's.
Remember the case, Joey?
I do remember him. Yeah.
Sometimes there's just too much matter. You know, there's no way to break it up small enough that that much is going to pass.
Can I ask you a question, Dr. Metzler?
Yes, of course.
What do you think about, sometimes I got this thing in my mind. What do you think if we can take a part of it, do a stage procedure, like do a part of it, like, and after that, in the second time, do the rest? What do you think?
Yeah, I think you have to be really strategic with the placement of your shocks, and I'll also be thinking about, you know, where is the shock traveling through? Because, you know, obviously you want to get say it's a complete staghorn down to the UPJ. You want to start breaking up the UPJ first. That's obvious, but the stone, you know, the shock wave will transmit through the calyces as well. So you may end up breaking quite a bit of stone. And that will build up. And of course, I would put a stent in, although that's not necessarily going to save you, because it can still obstruct. And I've had this problem with a patient that I did. You know, she had calcium phosphate complete staghorn stone with very long infundibuli, and I did a double puncture, and her last calyx I just couldn't safely reach, and I didn't want to puncture her a third time, and it was up underneath the lung. She was a very big lady, and so I ended up shocking the last calyx, and even though it was just one calyx, it was 2-3 centimeters worth of stone, and she ultimately obstructed despite having a stent, and had to have a stent exchanged twice, and then I had to go up with ureteroscopy to fully clear her. So I mean, I think it at that point comes down to your preoperative counseling. And it sounds like you tried to talk sense into this guy and he wouldn't have it. But I think it's, you know, setting expectations and saying, you know, you've got a boulder in there that we have to clear out, and it's not going to be easy no matter what way we go.
Okay. Okay. A personal question now, directing to you. What do you prefer? What do you favor for, let's say, a 1 centimeter stone? Would you like better have the PCNL or the SWL?
I think a 1 centimeter now is I would feel pretty confident either doing shockwave or ureteroscopy for that. Now we do a mini percutaneous approaches with really small nephroscopes and small suction catheters. The suction really helps with that because you can pull pieces out through the puncture sheath, and we use something called a clear Petra, and it's not a balloon, so it's less expensive, but you have to get a 14 or 16 French sheath into the kidney, which is not so easy. So you have to kind of do serial dilation to get it in there. But once it's in there, it has suction capabilities. It has this little side port where you attach the suction to it, and you can break up stones and suck out the pieces with the sheath itself. And that allows you to get a lot of stone cleared through as small as a 14 French clear Petra sheath. And that's really nice, but for a 1 centimeter stone, unless it's in the lower pole, and I know because someone else tried that it's really hard to reach, I would favor shockwave if it's in the upper pole, or proximal ureter if the patient prefers that. But I think more commonly, I just do ureteroscopy because, you know, we have the flexible ureteroscopes, and now high-powered holmium and thulium lasers let us get through a lot of stone pretty quickly, and I can get a 1 centimeter stone done, you know, in less than an hour. But
okay,
obviously that's highly technology dependent. I think you can really effectively treat a 1 centimeter stone with shockwave.
Okay, thank you. Because
that's what this is about. So the cutoff with the AUA guidelines, you know, for uncomplicated, now we're just talking ureteral stones, less than 10 millimeters, you can do observation, obviously, expulsion therapy. Do a lot of your patients get Flomax or tamsulosin prescribed?
Absolutely.
Yeah.
Yes.
So I think
yes,
the
we do that.
data, the data is mixed on whether that really helps. They've done large randomized control trials showing no significant difference. That's including a large number of stones. And I think if you narrow it down to stones above 5 millimeters in the distal ureter, the
Exactly.
Flomax still shows a benefit. Yeah.
That's exactly what I was going to say, because I remember when they first talked about this, the efficacy of tamsulosin, but they precise that it was for the distal ureter.
Mm-hmm.
But now I hear that it's for the whole length of the ureter. Is that true? That's what I knew. It was for distal.
Well, it ends up being used for anybody with an obstructing stone, and even in cases where the stone's non-obstructing, just sitting up in the kidney, your average emergency room doctor or primary care doctor doesn't understand necessarily the difference sometimes, and so they just hear kidney stone and think tamsulosin. Now, obviously, that doesn't work. You really got to, I think, limit it. The studies show that the alpha receptors really only exist in higher numbers in the distal ureter. So clearly, the mechanism makes sense there.
Okay.
There is also kind of a few increasing studies about prescribing sexual intercourse for patients with distal ureteral stones, and that it actually helps with passage of stones. And I think it's unclear whether that's the physical activity associated with sex or whether that has something to do with the endorphins or things that are released with orgasm or ejaculation. But it's kind of interesting that association's been described a couple times, including at our most recent Western section.
Even though I don't see a patient having a renal colic having intercourse.
I know, and it's a little bit of a sensitive subject to prescribe, especially if his significant other is in the room with him. But that's what the data shows. I think we often get into a situation where we see the patients 4 weeks after they initially presented to the emergency room. Maybe they've been on Flomax, maybe not. And, that acute renal colic episode is such a strong, symptomatology, and it often abates after, a few days or weeks. And so by the time they come see us, maybe their pain is gone, or it's certainly lessened, but they haven't seen the stone pass. And so the question then, of course, is, well, what do you do? Do you, re-image them or look up? And our guidelines say that you can re-image them, but you want to limit radiation. So sometimes ultrasound and X-ray is adequate, but it often won't show you those distal ureteral stones. So it's often not that helpful. And if you have to get a repeat CT scan, there's the cost obviously associated with that. And then there's also the radiation that you're giving them. So what's your experience? What do you do if a patient comes in weeks later, and their symptoms are better? Do you just check for hydro?
We usually chose the cheapest imaging method, so that would be the X-ray, the KUB.
Yeah.
But the thing is, theoretically, the KUB would show you stone from 5 millimeters and up. That's what it says. But if it's more than that, well, and
well, you may be blessed with a lot thinner patients than I see, but my average patient, a KUB often doesn't show me anything in the distal ureter because it's just too much fat and too much, bowel gas and things like that.
Yes. Okay. Mostly, what's the composition of the stones in your practice? Mostly.
Calcium oxalate is still the majority. I see quite a lot of calcium phosphate stones as well, even though that's not common. They're often more complex patients, and so they get referred out to me from the general urologist.
Okay.
I think, ultrasound in this situation is also really helpful. It may not show you the ureteral stone, but it rules out blockage. And that's, I think, at the end of the day, what we're most concerned about is a silent hydronephrosis that, causes renal deterioration over time.
Yes, we usually start with the KUB, but if the symptom persists and the KUB doesn't show anything, we ask for the ultrasound. Definitely, we have no choice at that time. But we try to protect the pocket of the patient the most that we can.
Yeah, we need to do that more here too.
Yeah.
So mid or distal ureteral stones less than 10 millimeters, is shockwave or ureteroscopy appropriate? We in the US tend to lean towards ureteroscopy because of the higher stone free rates. But again, we're working with flexible scopes, and there's nothing more frustrating when the stone gets pushed up in the kidney when you're using the semi-rigid. And I think if you have a good view of shockwave, that's totally appropriate.
Okay.
And I think the benefits here, shockwave has a lower complication rate than ureteroscopy, so it's an advantage there. There's less pain and morbidity associated with that. And the downside, I think, is that the ureteroscopy, at least in U.S. studies, the stone free rate at the end of the day is a little bit higher. So, but it's trade-offs, and I think I tell most of my patients that both are appropriate treatments, and it's really up to them and the trade-offs between having a stent, for example, and the discomfort associated with that versus the discomfort of passing fragments,
Okay.
And a lot of people that have had stents, boy, they prefer to go through passing the stones.
Indeed.
And then some special cases here. Obviously, uric acid stones are harder to see on fluoroscopy, and so ureteroscopy is more helpful in treating those. Cystine stones are known to be resistant to shockwave. So if there's any patients that have really strong family history of cystine stones, or of stones, period, or if you are able to test for cystine, or you smell that sulfur during ureteroscopy, then that's a patient that's probably not going to be effective with shockwave. Struvite stone, yeah.
Yeah, in Haiti, I should say that cystine and uric acid stones are very exceptional.
Yeah,
they're very exceptional. Maybe we miss them because if you don't have a CT scan or a good ultrasound, you might miss it. But they are very exceptional. What would you say? Yuri?
Yeah, I agree. But I have another question. If you're done with this.
Yeah.
Yeah, about the cystine stone. Do you think the Huntsville unit is not useful at all to know if you can break the stone or something like that?
Yeah, I think it still tells you something. I mean, I think if you see a cystine stone with lower Hounsfield units, you might be more able to try the shockwave, but I know that just based on the kind of molecular configuration of how the crystalline structure is, it's just resistant to shockwave, and so it's less likely to break up. And so I think you just have to really proceed with caution. And if you can reach it with ureteroscopy, you're probably going to have better luck. And those patients are going to repeat form stones. And so, if they have non-obstructing renal stones, you don't necessarily need to go after those unless it's forming something big enough to obstruct them. So if you wait, until they start to pass, I think that's appropriate too.
Okay, thank you.
Struvite stones are kind of another situation where I would prefer ureteroscopy just to get more clearance of the stone material. I also, you asked earlier about a 1 centimeter stone. Would you do PCNL for that? If patients have recurrent infections or they've had previous ureteroscopies and their stones seem to come right back, I often worry that that's because debris left in the kidney doesn't clear completely, and therefore you're never going to get the bacteria all the way out. And I will also treat them for more extended courses, like a week or two, with antibiotics right after surgery to allow them to clear those fragments in in urine that's not infected. And then patients with a bleeding disorder, you want to really be careful with shockwave as well. Perirenal hematomas can definitely happen with shockwave, and asking about a history of easy bruising, bleeding in the family, bleeding complications with other surgeries is definitely a good idea before proceeding.
Can I?
Yeah.
Yeah,
Please.
I would like to know if you have this perirenal hematoma, what do you do exactly? Do you leave it to go out by itself, or you can like drain it, evacuate the hematoma? What do you do mostly?
Yeah, I mean, obviously, if the patient's unstable at any time with low blood pressure, tachycardia, anything like that, you'd treat it like a renal trauma. That's exceedingly rare. I think with shockwave, it's usually just a small perirenal hematoma or flank ecchymoses that you can see afterwards, and that'll usually resolve with conservative management. Maybe bed rest in concerning situations where the hematocrit continues to drop. However, the patient would have to be unstable for me to want to go in and open the patient to evacuate the hematoma. And I think that putting a drain in it in general just decompresses it and allows it to bleed more. So, and drains don't drain blood very well, as I'm sure you know.
Okay, thank you.
The data shows that preoperative stenting and routine shockwave lithotripsy is not necessarily recommended. Now, we just talked a lot about that, and I think that your average shockwave patient here in the United States is going to be less than a centimeter. That's our guideline. And so, stenting for that smallest stone is probably not necessary. And I think you brought up a great point about the overall density of the stone. But in cases where the stone is a lot bigger than that, I think stenting is pretty wise. After ureteroscopy, do we always put a stent in? I lean towards putting a stent in if I've done a semi-rigid, because I think that torques on the ureteral orifice quite a bit and causes a lot of swelling and inflammation. Do you ever do ureteroscopy without placing a stent?
Yeah, sometimes we do that. It's the stone is not too big, and we didn't damage the ureter, so we don't put the stent. But if we have any issue, any concern about the ureter, so we put it in to let it heal around it.
How often do you leave them in for most of the time?
I can say half cases, or 60% of the cases we've been doing so far.
And then when you leave them in, how long until you take them out?
It depends how bad is the injury. Sometimes you can go up to 1 month up to 1 month. After that, we take it out.
Yeah, and sometimes less than a month.
Yes, if it's not a big damage, we don't feel like concerned to leave it more than that, so we can remove it 2 weeks. It depends.
Yeah, and as I'm sure you all know, I mean, there's nothing worse than dealing with an encrusted stent. And so in these stone formers, I always, I worry about that stent staying in longer than a month. I totally agree with you. And getting it out early, if we leave stents in, but we think that there wasn't a true injury and we're being just conservative because of worry about swelling or something, that I'll take it out. I'll leave it on a string sometimes and have them take it out as early as 3 or 4 days after the procedure, but I would not do it any sooner than that. And I really only leave them on a string if I was kind of hedging not leaving a stent in the first place, because they do get pulled out very often. And then when I do flexible ureteroscopy, if I'm treating an intrarenal stone and I didn't do any lasering and I didn't use an access sheath, I try very hard not to leave a stent, and that's usually successful. But if I use an access sheath, or if I'm torquing on the ureteral orifice with a semi-rigid, or if I did a lot of lasering in the ureter and the stone was impacted, those are the times where I leave a stent. Do you all have access to access
Dr. Metzler.
Yes, sir. Dr. Valman?
Yes, in case of a pregnant, patient with renal colic, how long can we leave the double J stent?
Yeah, great question. That is a tough situation because the patients are miserable if they have an obstructing stone, but you make them even more miserable when you put that stent in. I don't know what your access is to having nephrostomy tubes, but if a patient is early, say in their second trimester and still have a ways to go, I sometimes favor a nephrostomy tube over a ureteral stent, although that can be hard to convince the patient. But oftentimes the bladder symptoms in pregnant women with, the gravid uterus, the bladder symptoms are severe and they really hate you. To answer your question, how long can you leave it in? I try to change the stent every 3 weeks, which is a lot of trips to the operating room because they get encrusted so fast because the urine calcium in pregnancy is extremely high.
But don't you think that doing a nephrostomy in a pregnant woman is more aggressive than putting a double G stent? Yes, I understand that the bladder symptoms are very annoying during pregnancy, but the invasiveness of the nephrostomy, anesthesia and everything during the pregnancy, don't you think that might put the pregnancy at risk?
So we end up usually putting up our stents under anesthesia as well. I understand you can probably do it without that, but at least in our population, it's a hard sell. And so they often get anesthesia for our stent placements. And so the anesthesia risk there is the same. We often have fetal monitoring available as well, especially if they're in late second or early third trimester. So we have a lot of resources to put towards that makes it less of a difference. I agree with you though, putting a nephrostomy tube into a kidney is always higher risk than doing something endoscopic. We often will use small 10 French cope tubes, the tubes with the curl on the end, and it's a pretty small incision there, and you pass it over a dilator over a needle, and so I think that the bleeding risk associated with that is low, but I also think that you have to feel confident in the radiologist that's helping you, or if you're doing it yourself, it's something that you feel comfortable doing and you do often. How do you all get nephrostomy tubes when you need them?
Well, we don't do too many percutaneous nephrostomy. We don't do too many. Even only if we have a big, huge hydronephrosis, yes. But in a normal kidney, we are not too good in doing percutaneous nephrostomy.
It's hard. And are you using ultrasound guidance entirely?
Yes, ultrasound guidance most usually, yes.
Do you have radiology or any interventionalists that can help you with that, or is it's up to you?
No, it's up to us. We do everything.
Yeah, it's challenging. I think, in these cases, they often have hydronephrosis, which is helpful. And you can use ultrasound guidance, but the ultrasound imaging is very technology dependent too. So even in the last 5 to 10 years, the ultrasound technology has come a long way and made that easier. So that technology, is more widespread. I think that will help. And I encourage you to look at the video that I mentioned and that we'll send out after this talk to kind of just review some of the tips and tricks about that, because it's potentially life-saving if you can't get that stent in. If they have an impacted stone or diversion or something, and your only option is a perc, it's really critical. And I'd love, once our travel is available again, I'd love to do a workshop with you all, and I have some models and things that we could practice on.
We are dying for that, believe.
Yeah, and thankfully the ultrasound technology is getting cheaper and cheaper, and so I think that's the future. A lot of people in the U.S. learn to do PCNL and percutaneous nephrostomy tube with fluoroscopy. I find ultrasound better. Now fluoro always has its uses and can get you out of trouble sometimes, but ultrasound is really, I think it has a shallower learning curve. It's easier to understand and pick up than 3D fluoroscopy, and in those hydronephrotic kidneys and thin patients, it's something that any of us can master.
We used to do cyst puncture under ultrasound guidance.
Yeah.
Well, the cyst is much easier to access under ultrasound than non-dilated kidney.
Oh yeah, I mean, a non-dilated kidney still presents problems. I'm not saying that. I mean, I think really it's the hydronephrotic kidney that is your first, the first step, and those are often the cases that need it. So it's definitely a tool to get into your tool belt and can be really helpful. And it's much more like puncturing assist.
I would like to say something about the percutaneous nephrostomy. It's even worse for us because we can barely find the nephrostomy kit in Haiti. Even if we had the training to do it,
that's a good point.
we cannot find the kit. It's very difficult to find it. Only if you have a team coming from the States or in another hospital where someone donated it to that hospital. So
yeah,
I think
that's a great point.
Yeah, it's not easy for us to do the nephrostomy right now.
What kind of wires do you have?
What kind of what?
Wire, we got hydrophilic, we got stiff wires, we got sensor tip, we got a bunch of.
Yeah. I mean, I think, you don't need the cope tube. You don't need a kit to do it. So if you have a long needle, like a spinal needle for epidurals that is at least 18 gauge, so you can get a 0.038 or 0.35 wire through it. I use a stiff wire, and then you can dilate it with whatever you have. Central line kits often have little dilators in it that are pretty cheap, or you can get just a PTFE dilator that's 10 centimeters long for a couple of dollars. And if you dilate up the fascia, you can often get a Foley in, and even a 12 or 14 silicone is kind of nice, stiffer if you have those available. But after our percutaneous nephrostomies or percutaneous nephrolithotomies in residency, we would leave a 16 French Foley catheter that's just latex. Now, granted, that space had been dilated to 24 or 30 French, so it was easy to get the Foley in. But a Foley will do the job.
Okay. When what you just recommended, do you use a stylet inside the catheter so it can pass easier?
If I had dilated already, like if it was after a percutaneous nephrolithotomy, you don't really need the stylet. The problem is, I would place it over a super stiff wire and make sure it's well enough dilated. And if you're over a super stiff wire, it's hard to get the stylet in and still have it go smoothly. And so the key is really making sure that your fascia is dilated well enough that the tube will go in relatively stiffly. But you could try getting the stylet in next to the super stiff. I've never tried it. But the silicone's stiffer, and then I think if you pre-dilate well enough and have a super stiff wire, and you can get the smaller Foley, like a 12 or 14 in, and then I just put 5 cc's in the balloon, not the whole 10.
Mm-hmm.
You said, Dr. Metzler, you said when you have to put the double J stent in the pregnant woman, you change it every 3 weeks.
Yeah,
you don't have any concern about the anesthesia that you're giving so often to the patient for the baby? I don't know what kind of anesthesia you do, if it's a general anesthesia or spinal to do that. But
don't usually do a spinal. We'll either do just sort of a gentle monitored anesthesia care with propofol and some temporary, ventilation assistance or general anesthesia. And yeah, I mean, I agree. It's a concern. It's not something well studied. But as far as we've seen, there hasn't been any, poor outcomes linked to that. There is a higher rate of, preterm labor in patients that have had, that have stones, ureteral stones or obstructing stones. But as so far, I don't know of any data that's dissected out whether ureteral stenting versus percutaneous nephrostomy is, decreases or increases that.
Okay.
Okay. How long do you usually leave a ureteral stent in a pregnant woman if you don't see any stone either on, in the ultrasound? Because mostly that the ultrasound that you would use, right?
Yeah.
Okay, you know, CT scan. So if you don't see the stone, but you have a diagnosis, you have a slight dilation of the kidney cavities, and you don't see any stone, but if the patient is in excruciating pain, so you leave a stent for how long?
Well, I think, yeah, it's a hard problem. I hate that consult because there's no good way out of it. And one interesting thing when I came to Oregon is that different than where I trained, where I don't think ever got a CT scan on pregnant women. The OBGYNs here felt that it was better to know whether there was truly a stone or whether it was physiologic hydronephrosis. And so some of our patients get CT scans despite the patient being pregnant.
Well, but besides the dilation that you have, you might have the pain also. The pain with the dilation makes the diagnosis. So
right, but you can have physiologic. I've seen patients that have physiologic hydronephrosis and renal colic, but no stone.
Okay.
And that's a very frustrating situation because I try very hard to convince that patient to continue conservative management of the pain, especially depending on where they are in the in third trimester, how long they have till they're going to give birth, because the discomfort of the stent is always something that they often regret because it's so bad. So I have to be pushed pretty hard to stent them unless I know that there's a stone there or if there's concern about UTIs. So the other thing you don't want to miss is if patients are showing, if they have a leukocytosis or low-grade fevers and chills, that you don't have a obstructed hydronephrosis and pyelonephritis on your hands. That certainly is a reason to stent right away.
Okay.
And then I think your question was, do you take the stent out after they're, after you've stented them for a while? To me, I don't know when you would do that because their uterus is just getting bigger and bigger until the baby's finally born. And so I end up just exchanging the stents. Have you done it where you've stented them for a period of time and then taken it out and they've been okay? I would be very interested.
Christian.
I got some experience in this. I think I did like 5 or 6 cases like this, but I used to change it every 3 months because as you said, the problem is still here. Once the baby she still got the pregnancy, the compression is still there. So we cannot remove it. I change it, but I used to change it every 3 months without any problem. But this is
so
the
you
reason
didn't see
why.
bad incrustation at 3 months?
No, for the patient I operated on, I didn't have any trouble. And most of the time, they are very comfortable with the double J because they said the pain was worse than what they're having now. They can tolerate what they're having now as opposed to what they had before I put the stent in.
In comparison, the discomfort with the double stent is much more bearable than the renal colic.
Yeah, that's good.
You have to
that means you're doing the right thing.
I know in the States it's a no pain politics that you have, right? But in Haiti we try to
Yeah,
The
well,
good news is our patients are more compliant.
yeah,
Yes,
they probably
they
don't come
definitely
in
come
until
up
the pain is
definitely. I know in
severe.
the state, it's a no pain game.
No pain game, that's right. They trade the pain for other pain.
Yes, yes, yes.
It's hard to win that battle.
Indeed.
So this was another kind of just interesting case here. You can see on ultrasound, this is kind of a good picture of this condition. So anybody can shout it out if you know it. This is the same patient, their ultrasound and then their coronal CT scan.
Hey, that would be Staghorn or okay, all right. A lot of calculus, all right.
Well, no, so it's not. It looks like a staghorn because you see the shadowing and all
Yes,
these
in the ultrasound, but
calcifications.
on the CT scan, it's much
Much
obvious.
less.
Yes.
And it's actually the papilla that are calcified. So this is nephrocalcinosis. And so, and you can see here on the ultrasound, it's a nice picture of how, you know, you see a couple shadowing areas. So on ultrasound, the stones themselves will often shadow, but you can see that the papilla themselves, the entire papilla and calyx is very hyperechoic, so very bright on ultrasound. And that's a sign of nephrocalcinosis, where it's actually the tubules in the kidney that are getting calcium deposits, and those are not reachable with any therapy. So you wouldn't want to shock this patient. You wouldn't want to put them through ureteroscopy because it's just in the meat of the kidney.
Yeah. As a differential diagnosis, can we evoke maybe a medullary sponge kidney too? No.
100%. Yeah, the similar problem. I think, you know, the difference between the two may be just in the underlying space that the calcium is in, whether it's in the actual tubules or whether you're getting the kind of sponge pathology. But on imaging, the characteristics or the phenotype is very similar. And these are challenging patients because they obviously do have stones. You know, the stones will form off of these calcified papillae and will pass and kind of obstruct them. But we're kind of, you know, working in the dark here because there's so much calcium on their imaging studies. It's hard to know what's going on. So I often look, you know, we have to rely on their symptoms. We have to, you know, assess for hydronephrosis or obstruction or stones in the ureter. And I think, I don't have a picture here, but just plain KUB can be quite helpful in these cases.
Absolutely.
Especially over time.
What approach do you recommend for these cases?
What's that?
Yes, what treatment do you recommend? Maybe
well, it depends on what the so I wouldn't perk this lady even though she's got a lot of calcium, because I'm not going to be able to reach it, you know. You don't want to go after the stones that are in the meat of the kidney because you're just not going to be able to get it out. And what you have to look for instead are stones that are breaking off or forming separately and obstructing, and treat that, you know, independently with either ureteroscopy or possibly shockwave, although the shockwave imaging is going to be challenging too, because you have to know which one of the radio densities is the one obstructing her. All right. So then with regards to renal stones, so moving out of ureteral stones, but onto renal stones, 9mm upper pole stone, can you offer surveillance if it's asymptomatic? Our guidelines say that you can. And, you know, I think for, you know, you all in Haiti with, you know, limited ureteroscopy, that you can watch these stones. Our cutoff is really the 10mm, but I think it just depends on the situation. Shockwave in the lower pole stone is appropriate in times, but we have the cutoff of over 10mm in the lower pole, and that's just because, as you know, the pieces have to pass, and they're much less likely to do so in the lower pole.
Okay, I did not know this limitation for the lower pole kidney. All right, thank you. It's a good point.
You know, after our percutaneous nephrolithotomies, it was often normal practice to leave a nephrostomy tube in. And that's not necessarily a recommendation. You can either leave a ureteral stent and just close up the percutaneous site, or leave a nephrostomy tube, or you can leave both. It really depends.
Does that depend on the bleeding? No.
Yeah, absolutely. So, you know, the classical teaching is if there's significant bleeding from the site that you leave a tube in. I'm a little bit skeptical that truly helps unless it's a large bore tube. You know, if we put in just a 10 French cope tube, I don't think that does very much for stopping bleeding. If you put in a 24 French latex Foley catheter, you know, that makes a little bit more sense to me. Or certainly a tamponade balloon on traction would give you the most pressure to stop serious bleeding. But in the vast majority of my percutaneous nephrolithotomies, you know, the bleeding is mild. And if you hold pressure on the site for a couple of minutes, you get almost nothing other than skin bleeding from the site. And so I will often put a stent down the ureter and then leave nothing in the back. And I just close the back and call it a day, because I think that for your average, you know, puncture, and the size I use now is, as my standard, is 24 French. I think that heals up nicely, and I haven't seen, knock on wood, you know, significant bleeding events from that.
Okay, on a practical standpoint, does it make any difference to leave a nephrostomy tube for 24 hours, or doing just leaving just a stent?
Yeah.
Does it make a big difference? Practically.
I don't think so. I don't leave a nephrostomy tube as my standard. I've trained with people who did, but I think that unless you're concerned about infection or, you know, significant bleeding, like you mentioned, or if you think that even with a stent, the kidney's not going to drain well enough and you're going to get a urinoma, then I would consider leaving one. But I think the patients do very well with just a stent, and, you know, it's a easier discharge in the morning if you don't have to worry about the tube coming out of their back and capping it and seeing if it drains well or not, and wondering if there's going to be swelling of the ureter that's going to prevent it from draining. I think you're much more likely to get a urinoma or a persistent leakage from that site if you don't leave a stent and try to get a nephrostomy tube out even post-op day 1. But it's very case by case. And it's never wrong to leave both. One thing they are pretty strongly worded in their guidelines about PCNL is that you should do flexible nephroscopy during or at the end of your PCNL. And that's because, you know, with the rigid nephroscope, you just can't reach all calyces. And no matter how skillful you are, pieces, you know, can fly off, and you know, you want to make sure that you're seeing all parts of the kidney, and you can only do that with flexible nephroscopy. Now, I do that sometimes with my flexible ureteroscope that I will often have up at the same time because I work with residents, and we're working together clearing the stone out. But you can also just use a flexible cystoscope through your nephrostomy tube track and make sure that you've cleared all the fragments. And then normal saline is the only recommended irrigant during PCNL. So this is how our guidelines break up. And again, I think this is very location and technology dependent, but basically if the stone's less than 10 millimeters, anything's appropriate. And still up to 2 centimeters. If it's in the upper or middle pole, that's fine. The lower pole is when, you know, if the stone's over 1 centimeter, that you're going to have a harder time clearing those fragments. And then generally for stones over 2 centimeters, we recommend doing the percutaneous approach, or possibly in your situation, you know, staged shockwave lithotripsy. And again, these are guidelines. I'll tell you, in practice, I see a lot of private practice doctors that are just not comfortable doing percutaneous nephrolithotomy because not every urologist is, doing staged ureteroscopy, stenting them, staged ureteroscopy, sure, but also staged shockwave lithotripsy, and stenting them, shocking them multiple times. So I don't think it's necessarily wrong. It's just not within our guidelines, and I think that you have kind of harder time clearing all the fragments, but often it's enough to treat their symptoms. And the times that you really want to worry, about getting every single little fragment is if it's a patient with struvite stones and infection, because if you leave anything, they're much more likely to have a recurrence and to continue to have infections. And, recurrent stones, calcium phosphate stones, if you have a sense of whether that's the patient that you're dealing with. And then, otherwise, I think if you treat the bulk of the stone that's within the renal pelvis or ureter, their symptoms are likely going to improve. We were allotted for an hour, but I'll just go a little bit more if you all are doing okay.
Dr. Metzler.
Yes, sir.
Yes, in case of ectopic kidney, would you rather do URS or PCNL?
So are you talking about something like a horseshoe kidney?
Yes. Ectopic kidneys,
ectopic?
whatever.
Well, it depends. I mean, you can have some really crazy ectopic kidneys that are floating in the middle of the pelvis, and you're really not going to have any percutaneous approach. Sometimes you can see, I deal with stones in kidney transplants sometimes, and those are in the pelvis, in the extraperitoneal space, and you can often find a clear window to puncture in and treat their stones just like you would through a flank in a native kidney. Horseshoe kidneys in general, which I think is the most common type of ectopic kidney, those are still appropriate to approach with a percutaneous approach, although you often have to go more medial, and are often going for an upper pole puncture as the most clear puncture because the lower pole is more medialized and harder to access. Ureteroscopy can be very challenging in those patients with horseshoe kidney because there's often redundant ureter and it comes in at a very high angle and it's very hard to get to the lower pole. And I think with a semi-rigid, it would be almost impossible. Shockwave is also really limited because of how low the kidney is. So those are super challenging. Have you seen many of those or treated many of them open?
Not at all for me. I never treated any case like this.
Sometimes the pelvis.
I saw a few cases in India like that.
Sorry, Dr. Bellamy?
He said he saw a few cases like this when he was in India.
Yeah, so oftentimes, if it's a horseshoe kidney and there's any obstruction, they'll get a pretty dilated calyx. And so you can actually have pretty good access from either an open or laparoscopic approach to doing a pyelolithotomy where you dissect out the pelvis of the kidney and open it to get the stones out. So that's another approach. So I'll just fly quickly through and we'll end in the next 10 minutes or so. Safety wire is recommended for ureteroscopy surgery. So, you don't need it till you need it. And then when you need it, you really need it. And the only way to make sure you have it is that you leave it ahead of time. Repeat procedures are offered to clear stones. That's a recommendation. And then if you encounter purulence at any time during endoscopic cases, it's really recommended that you take a culture from that fluid because the discordance rates between urine cultures, which you should be getting before endoscopic surgery, and the actual renal culture is as much as 30 to 40% discordant. So, in patients with obstructing stones and infection behind those stones, it's not always reflected by what's in the bladder. And so if you're able to get some of that fluid and send it for culture, you're more likely to be treating the appropriate organism. Here's one more bonus case here. This one's a little subtle, and it's not actually a stone case. It's a patient that was referred to me for bilateral hydronephrosis, and they were concerned about bilateral ureteral stricture, but he had never had surgery in his abdomen. He had never had stones. He had never had ureteroscopy. So what would be on your differential here, kind of looking at this hydro and the outline of these kidneys?
Maybe a UPJ obstruction. I don't know. Yeah,
the UPJ obstruction would definitely cause the hydronephrosis, and you're right in that, you know, it was only hydro in the kidney. But if you look at the kind of the outline of the kidney, you can see here you got a normal smooth capsule. Hopefully you can see my mouse, but a normal smooth capsule, and then medially you see kind of this irregularity and this denser tissue. And if you look at the retroperitoneum behind the left kidney, so posterior left kidney, you can see there's a few kind of denser dense tissue nodules. And it turned out that this was actually a patient with retroperitoneal or perirenal lymphoma that was causing obstruction. And so he ended up having one of these nodules biopsied, and it showed lymphoma. You can also see retroperitoneal fibrosis cause this kind of out of the blue, and that's a really challenging thing to deal with. Have you all encountered that, or had patients get surgery for that? Yeah, retroperitoneal fibrosis is an autoimmune disorder where fibrosis within the retroperitoneum causes medialization and narrowing of the ureters through extrinsic compression, and often they need steroids or another immune suppressant. But if they develop bad enough strictures, they need to have ureterolysis, where the ureter is freed from the retroperitoneal space and then moved into the peritoneum. And that's usually enough to allow the kidneys to start draining again. Okay, and then just a few cases in pediatrics. Have you seen many pediatric stones?
Not really, Yuri. I don't know for you, but excuse me, a question for the the retroperitoneal fibrosis. When you do the surgery, what do you use when you transfer what do you do, like for what technique do you use? Do you transfer the ureters into the abdomen, the peritoneal cavity?
Yeah, we basically free it up circumferentially, trying to preserve as much periureteral tissue as possible to preserve the blood supply, and then put peritoneum underneath it so that the ureter stays out of the retroperitoneal space. We don't disconnect it, or we don't do a ureteral reimplant or anything, but we just free it up completely. And then if you're concerned about blood supply, you can always move omentum and do an omental wrap.
Okay.
And in some cases, I've only done this a few times, but there's increasing use of buccal grafts to help with discrete strictures, not necessarily in the case of panureteral stricture or retroperitoneal fibrosis, but in discrete, iatrogenic strictures that have failed additional other therapies. There's been some reported success with using a piece of buccal, like for urethroplasty, but on the ureter, and then putting in a omental flap.
Yeah.
I'll just skip the pediatric portion because we have a portion about pregnancy, which we talked about. So again, a kind of observation, if a patient has a 5 millimeter stone in pregnancy, and avoiding procedures is the best. But if patient's clearly obstructed and unrelieved in their pain, we generally recommend ureteroscopy. We do not recommend shockwave in pregnant patients. It's a contraindication. due to concern about loss of the fetus. And then, yeah, so every 4 weeks was the question. We already asked about how often to exchange stents in pregnant women, but clearly you can get lucky and go longer. And then one last case here, and then does anybody have any familiarity with this? Is a really weird one. I got referred from out of state. Any takers on what this looks like or the name of this pathology? This is obviously large staghorn kidney stone, but you can see that the kidney outline has been completely replaced by fat density on CT scan. And this is a really rare condition called renal lipomatosis. It's benign, but clearly has.
Would you say that again? Renal what?
Lipomatosis.
Oh.
So it's a replacement of the renal parenchyma with fat cells in this benign proliferation, and it's associated with chronic obstruction and kidney stones.
How about what they call, I don't know if they still call it like that, xenogranulomatous pyelonephritis? No?
Yeah, so that's associated, but this is a different pathology. It's a really a proliferation of fat cells, whereas the first case I showed you where we had that stone and the really blown out kidney was a XGP kidney with the foamy macrophages and everything replacing the parenchyma.
Okay.
Hope not to see this again because that kidney's done. All right, well, I'll end it there. I would love to open it up just for any other questions. And I have really appreciated your insightful questions and sharing how your experience has been treating stones.
Well,
I mean, I think I'm good. I just want to thank you for this the lecture, the presentation. It was very interactive and very helpful.
I'm glad.
I don't
well,
have
it sounds
any
like
other questions.
It sounds like you've made great strides in the treatment of kidney stone disease with the technology you're adopting. I would love to be a resource for you all if cases come up and you want to reach out. Yori has my contact information. And I'm always available by email. Send me videos or questions. And I think that hopefully we'll continue to get technology widespread, and I would love to come down to help with any ultrasound training and get you all more familiar with doing percutaneous approaches, because I think that's super valuable.
You would need good training.
Yeah, I look forward to it. Hopefully we can put COVID behind us here pretty soon.
Well, thank you, Dr. Yori, for coordinating, and thank you, Dr. Metzler, for speaking, as always.
My pleasure. Have a good night, everyone.
Thank you very much.
Good
Until next time.
All right.